Here are the learning objectives for today's session. We'll be talking about the definition and types of hypoglycemia, signs and symptoms of hypoglycemia, learn a little bit about the risk factors. We'll be able to compare and contrast type 1 versus type 2, both in risk and rates. We'll talk about a rational approach to hypoglycemia based upon the setting it occurs in and the severity of the hypoglycemia, and then evaluate etiologies and the evaluation of hypoglycemia when it occurs outside of diabetes. Here's the outline for the session, and so we'll start with definitions of hypoglycemia and normal glucose physiology. So just at a very simple level, hypoglycemia occurs when the sum of glucose utilization exceeds the sum of glucose delivery. And so even though that's a very simplistic definition, the body has many systems for which it regulates glucose across a wide range of environments and physiologic stimuli, but the glucose stays relatively constant. And so it is important to recognize that the body is able to control this very eloquently. Hypoglycemia is best defined by Whipple's triad, which is typical signs and symptoms of hypoglycemia, with a documented low blood glucose, and then those signs and symptoms resolve with the resolution of the or correction of the blood glucose. And I know that sounds circular, but it's quite important because there are many things outside of hypoglycemia that can cause the signs and symptoms of hypoglycemia. And so we want to make sure that we're being specific with our diagnosis. So to orient to normal physiology, I think it's important to recognize that people without diabetes rarely drop low. And why is that? This is the really physiologic defense, or you can also call it the response to hypoglycemia. So in somebody who is normal, who doesn't have diabetes and is not taking diabetes treatments, it's exceedingly rare to drop low. And the reason why is that the body has multiple systems to defend against this. So if you look here, starting at a glucose even at 80, our primary defense against hypoglycemia is a suppression of insulin secretion. And so our body is actually able to regulate insulin secretion, as you learned in the pharmacology lecture, through a pulsatile release and a balanced release between insulin and glucagon. And so a suppression of insulin would be a great defense against someone dropping low. However, if the glucose continues to drop low, you trigger your primary counterregulatory response, which is glucagon secretion. And again, this is coupled with insulin, and it's sensitive to the glucose level. And for most people, these first two layers of defense are all we need to regulate our glucose across the spectrum of environmental changes and not drop low. Unfortunately, some people still can drop lower than that, and then we trigger our sympathetic nervous system. And when we do that, we get three hormones that are involved. First is epinephrine. This is a very rapid way to respond to hypoglycemia. You mobilize glucose very quickly, but you also get the typical symptoms that come with epinephrine release. And so many of the problematic symptoms for hypoglycemia are actually from the release of epinephrine. When you trigger your sympathetic nervous system, you also trigger an increase in release in cortisol and growth hormone. And while these respond much slower, they do protect you for a longer period of time, because then you get hours of kind of increase in glucose levels. And while this may be, again, somewhat mild for someone that doesn't have diabetes, someone that has diabetes that has to trigger a sympathetic nervous system response actually can then have subsequent hyperglycemia for hours because of this. And this can be very frustrating for them. And then finally, you'll start to trigger hunger due to neuroglycopenic symptoms when you get to the 50s. And we don't want to have neuroglycopenia, because once your glucose is low in the brain, which is an obligate glucose metabolic organ, you're going to have impaired cognition and impaired ability to take care of yourself. So the five levels of defense for you. Primary level of defense is suppression of insulin secretion. Second layer of defense is increased glucagon secretion. Remember, this does the lion's share of the work. However, if you go beyond that, you go to your third layer of defense, which is epinephrine. Fourth layer of defense is cortisol and growth hormone. And your fifth layer of defense is hunger. And because of this, we really are able to prevent severe hypoglycemia. Now let's apply this system as it relates to diabetes. So the top row we've already talked about. The person who is normal, who doesn't have any diabetes, or maybe they have early type 2 diabetes and they still secrete insulin, they'll have a normal response to hypoglycemia. First step is suppression of insulin. Second step is increase in glucagon. Third step could be increase in epinephrine. However, in type 1 diabetes, the pathologic defect is insufficient insulin secretion, often no measurable insulin secretion. So they are not able to instigate the first layer of defense because they don't secrete insulin, so they can't suppress it. And because insulin and glucagon are a coupled system, then they're not going to get the compensatory normal response in glucagon with an increase. So they're really relying on epinephrine to be their primary defense against hypoglycemia. And this is a very effective response, but it doesn't feel good, and it is a system that can be attenuated. So the more frequently that your glucose drops low, the lower the threshold will be for which you then trigger epinephrine release. So that becomes problematic if someone drops low a lot, because the glucose will keep getting lower and lower and bump against that neuroglycopenic threshold for which they're really at danger. And then the last row is it is important to recognize that those who have type 2 diabetes for 10 or more years often are inadequate in their insulin secretion. They have to take insulin exogenously, and their physiologic response to hypoglycemia in many ways may look like type 1 late in type 2 diabetes. So they're at increased risk as well. So the next two slides show you graphically the coordination of the system that prevents hypoglycemia. So in the top left corner, you have a decreased glucose. You can see that communicates with the pancreas, and the beta cells will decrease insulin secretion. The alpha cells will increase glucagon secretion, which has the net effect of also increasing hepatic glucose production. Then on the right-hand side of the graph, you can see that you stimulate the sympathetic nervous system, which will then mobilize and increase glucose and trigger the adrenal gland to secrete hormones that also will mobilize and increase glucose. And this is coordinated with feedback loops to be able to respond to both to hypoglycemia. Next, this is actually just showing you the same thing in just a different format, how hypoglycemia can affect insulin, epinephrine, and cortisol, as well as glucagon and growth hormone. And you can see the effects of these hormones as they move downstream and how they raise glucose. So let's do a case. Stefan is a 65-year-old male who's had type 2 diabetes for about 6 years. You asked him to get fasting labs done, so he came in for labs today. So he purposely did not eat. But he was worried about dropping low, so he didn't take his home medications. When he was getting his labs drawn, he told the lab tech that he felt shaky and hungry, and so she did a fingerstick glucose, and it was 284 milligrams per deciliter. So the first thought question for you is he hypoglycemic? And what kind of hypoglycemia is he experiencing? So in 2013, the American Diabetes Association and the Endocrine Society came up with a consensus statement for classification of diabetes, hypoglycemia in diabetes. So documented symptomatic hypoglycemia is a measured blood glucose lower than 70 milligrams per deciliter. And this is in the presence of diabetes. NASA has actually done some work, and they document hypoglycemia in the well adult below 60. For this presentation, we're really going to be focusing on diabetes, so we're going to use the American Diabetes Association definition. They also added severe hypoglycemia. Severe hypoglycemia is any glucose that requires assistance from other people to take corrective actions. So if a person is dropping low and they cannot feed themselves, or they cannot properly protect themselves, so someone has to either give them carbohydrates, glucagon, or take other corrective actions, that's a severe hypoglycemic episode, regardless of where that number's at. It could be 30 or it could be 75. But whatever value it's at, it's still considered to be severe and life-threatening. Equally as concerning is asymptomatic hypoglycemia. Asymptomatic hypoglycemia is a glucose below 70 not accompanied with any typical signs or symptoms. And this is important because, again, when we talked about in the normal physiology, if you start to drop low and you're relying on epinephrine to be your primary response, that threshold will continue to drop. And so those people who experience asymptomatic hypoglycemia are very likely to have been experiencing a lot of hypoglycemia and have an attenuated epinephrine threshold, and they're really at the highest risk for mortality. So asymptomatic hypoglycemia is also very problematic. And then the last two are probable symptomatic hypoglycemia. You're going to see this a lot in your practice. People will have typical symptoms of hypoglycemia, but they're not going to check their sugar, and they're going to treat it, and they're going to feel better. And so while it's common sense that many of these people indeed had hypoglycemia, we want to be careful because some of them might have symptoms from something else, or they might be being too aggressive with their treatment of hypoglycemia, and they're allowing persistent hyperglycemia. And so anyone who has probable symptomatic hypoglycemia, we really encourage them to continue to check their glucose when they're treating. And then the last thing is pseudohypoglycemia, and this is really what Stepan has. So Stepan has a person who has diabetes. He had typical signs and symptoms of hypoglycemia, but his glucose measurement was much greater than 70. And so and this is really a dramatic case. Most people won't feel these symptoms at that high level. But if someone's glucose is dropping at a relatively fast rate from a higher value, even if it's in the normal range, or if they're chronically hyperglycemic and their value is currently lower than it normally is, they can have pseudohypoglycemia. And so it's not nearly as dangerous as hypoglycemic episodes as documented above, but it is important to recognize and let the patient know that we might have to bring their glucose down more slowly so they feel better as their glucose starts to normalize. And then as an update, the American Diabetes Association, the European Association for the Study of Diabetes, in 2017 had an addendum to this classification. And the feeling was that many studies were being done with diabetes-related medications, and they were all using different levels of glucose to define hypoglycemia. And this became quite hard to define hypoglycemia, and it was hard to be able to compare across medications. So they came up with 3 levels of hypoglycemia. Level 1 is a glucose below 70, which is really considered an alert value because it's the level for which you start to trigger your counter-regulatory responses. Level 2 hypoglycemia is a glucose level below 54, and this should be universally declared as hypoglycemia, particularly in research studies, so that we can actually compare rates of hypoglycemia. And then level 3 hypoglycemia is severe cognitive impairment, or severe hypoglycemia, in which they need assistance from others, and there's no set glucose value. So this really matches the definition of severe hypoglycemia as defined in the 2013 statement. So now we'll move to the typical signs and symptoms of hypoglycemia. And what I can tell you is that every person has different signs and symptoms as related to hypoglycemia. It probably has to do with how often they drop, what their normal physiology is, what is the cause of them dropping. But people can also have different types of hypoglycemic episodes, again, related to the cause. And then when we look at the signs and symptoms, you can actually attribute them to the system that is being triggered in response. So we'll talk about adrenergic response. Again, this is from the epinephrine response. And so you can see that many people can experience palpitations, anxiousness, tremors, or irritability. You can get a cholinergic response related to sweating, hunger, or paresthesias. And then if you drop low enough, you start to get your neuroglycopenic symptoms. And so these really should be much more seen as much more severe symptoms because your glucose is lower. If they have confusion or a decrease in their senses, like decreased hearing, lethargy, or even the more serious symptoms of seizures or comas. So each time you see a person with diabetes, you should ask them, do they experience hypoglycemia? If they say yes, you ask how often. And then you ask, what are their symptoms? And it's important to be able to refresh that back to the patient so they can attribute these symptoms to hypoglycemia. And then you might also ask their family or their friends. Sometimes they'll know even before the patient will that the person's dropping low. And this is something that should be assessed at every visit for someone with diabetes. So now we'll move to etiologies of hypoglycemia as it relates to diabetes. So the most common cause of hypoglycemia in diabetes is related to the medications for diabetes. So by far, insulin is the most common. Insulin secretagogues such as sulfonylureas and meglitinides are the second most common. And we'll talk a little bit about the details of that. So for example, if somebody is mixed up their long-acting and their short-acting insulin and they're taking the wrong dose, that might cause them to drop low. If they, we will see patients who will miss one dose and then double that dose at the next dosing time. That can also cause hypoglycemia. And some patients will actually be very aggressive to try to normalize their glucose because they want to prevent complications, but do so at their own demise by causing increase in hypoglycemia. Probably the most common cause of hypoglycemia that I see in type 2 diabetes is the overuse of basal insulin. So you'll see that basal insulin, as you learned in the pharmacology lecture, is intended to be used to cover your glucose overnight and between meals. But sometimes we increase the dose too much, and when we increase it to actually intend to cover our meals, we put ourselves at risk for dropping low overnight. So overbasalization is a cause of hypoglycemia. We can also see the use of hypoglycemia occur in people with type 2 diabetes when we use medicines like sulfonylureas in older adults who have impaired ability to respond, or they have impaired renal function. So these are all important causes of hypoglycemia. You can also get it from defective or deficient physiologic responses. So if somebody who has had diabetic gastroparesis or a neuropathy of the stomach as a complication, they might not be able to absorb food normally. So they take food in, they trigger their insulin response to the food, but then they don't actually get to absorb the food that they think they're absorbing. We also see that for people who have had gastric bypass surgery. And then certainly there are a number of patient level things that can cause hypoglycemia. Somebody might skip a meal. So we commonly see people take their medications, go in for fasting labs, don't eat, and drop low. Or they're busy during the day and their medicine's working, but they didn't get their food. Or maybe they started to get to a meal and they ate less carbohydrates than they thought they would. It's important to remember that when someone is physically active, they're actually able to get glucose into the cells without insulin. And so if someone increases their physical activity, they actually could be at risk for hypoglycemia as well. And then certainly some people develop hypoglycemia recurrently because they didn't recheck to see if their first treatment was effective. These would be all cases as it relates to diabetes. There are a couple additional causes that I feel need a little additional attention. So somebody who is going to engage in a physical activity program, which we would encourage everybody with diabetes to do, you need to be able to take that into account as a response to your treatment. And let's focus a little bit on type 1 diabetes. So if someone is an athlete and they have type 1 diabetes, they're going to need less insulin for the period of time that they're exercising, and often for up to 6 hours afterwards because of an increase in metabolic rate. And so we need to have a plan to prevent hypoglycemia for those athletes. And sometimes that means suspension of their insulin. It could mean taking less insulin, or it could mean more eating additional food to prevent hypoglycemia as a response. You can also see hypoglycemia as a response to alcohol. Alcohol is a carbohydrate and actually initially raises glucose, but the metabolism of alcohol at the liver competes with the production of new glucose. And so your gluconeogenesis at the liver is suppressed while you are metabolizing alcohol. And for some people, that's enough to cause hypoglycemia. And then finally, people who have chronic liver or renal disease are at higher risk for hypoglycemia. And so particularly for older patients, if they suddenly start having hypoglycemia and you haven't had any reason to suspect that, no change in diet, physical activity, or medication, you should check their renal function and liver functions to make sure that they've not declined since you last assessed them. Now let's talk a little bit about the diabetes medications as it's associated to hypoglycemic risk, particularly in type 2 diabetes. So we've mentioned earlier that insulin and sulfonylureas and glinides are the high-risk medications. And insulin, of course, because you're replacing, you're actually giving super physiologic amounts of insulin, probably more than your body would do. And it's very hard to match identically a physiologic insulin release with exogenous insulin administration. When we look at oral medications, you've heard from the pharmacology lecture that some medicines cause a glucose independent insulin secretion. And so those medicines like sulfonylureas and glinides will work at whatever strength they're going to work, regardless of the starting glucose value. So if your starting glucose value is lower, you're actually going to induce hypoglycemia. And so it's very important that you educate your patients about this as a potential risk factor. The good news is the great majority of the medications we have for diabetes now do not have an increased risk. Some have a really low risk because they have glucose-dependent insulin secretion. So you learn that the DPP-4 inhibitors and GLP-1 receptor agonists, their effect on insulin secretion largely has to do with the starting glucose value. And so they work as hard as you need them to work, and that's a significant advance for us. We also know that we have lower rates of hypoglycemia with the insulin sensitizers, so metformin, TZDs, and then pretty much all of the other medications are relatively neutral as it comes to hypoglycemia. So I want you to know those medications that really put you at higher risk for hypoglycemia. This graphic is really just to kind of show you the relative risk compared to placebo. Again, the sulfonylureas and glinides are your highest risk, anywhere from 3.9 to 4.6 times higher than placebo, where you can see the rest of the medications are really equivalent to placebo in the risk for hypoglycemia. And so this is not the only factor that we use to decide on a medication, but it is one that you should consider. So how common is hypoglycemia in diabetes? And your second thought question, when you look at hypoglycemia, are there more hypoglycemic episodes in the world from type 1 or more hypoglycemic episodes in the world from type 2? So let's start with type 1 diabetes. In the Diabetes Complication and Control Trial, very large study of type 1 diabetes, they found that those people who were intensively treated with insulin were low, with a glucose less than 50, nearly 10% of the time, and 65% of the patients in that trial had severe hypoglycemia. When we try to quantify that into daily life, the average person in this trial with type 1 diabetes has 2 hypoglycemic episodes per week and 1 severe hypoglycemic episode per year. And that's really problematic because this means that they actually need to be rescued from somebody else. And then there is still mortality from hypoglycemia, so 2 to 4% of people with type 1 diabetes can die from a hypoglycemic episode. Just as a side note, early in type 1 diabetes, during the honeymoon period, you actually have a little bit of insulin secretion preserved, and you're able to trigger your primary defense. And so hypoglycemia is relatively uncommon in the honeymoon period or the early type 1 period. So as we apply these results of the Diabetes Complication Control Trial in type 1, you can see that from the right-hand graph, we're able to, as we reduce the glucose over time, we see that we get a reduction in retinopathy. So that's an important outcome. We want to reduce diabetes complications. However, as we go to the left-hand graph, as we reduce the A1C, we actually increase the episodes of severe hypoglycemia. And so we really need to find that balance of where do we get the maximum benefit with the minimum risk, because both of these are problematic if they are overrepresented. So what about type 2 diabetes? We know that in the UK PDS trial, which is a large study for type 2 diabetes, rates for hypoglycemia were actually lower than anticipated, but 2.4% of people on metformin dropped low. About 3% of people on sulfonylureas dropped low. This is a study of people newly diagnosed. That may be why that rate is relatively low. But 11% of people on insulin had a hypoglycemic episode. And we just mentioned, once someone got on insulin, their risk was essentially the same as type 1. And there have been other studies looking at national routine care estimates, and it's anywhere from 3 to 10 episodes per 100 patient years. Now, while that sounds like not very much, because there is 20 times the number of people with type 2 diabetes than type 1, the most common cause, the total sum of hypoglycemic episodes are greater in type 2 diabetes than in type 1, even though the person individually is at a higher risk with type 1 diabetes or late type 2. We also know that hypoglycemia is missed. We're not asking our patients enough about it, patients aren't recognizing it, and that they're having more episodes than we suspect. This is actually a study that was done out of our center by one of my diabetes fellows. And we wanted to apply what is the real world rate of hypoglycemia in type 2 diabetes. So we enrolled 108 patients with type 2 diabetes, and they could be on any medical treatment. So they could be on metformin, insulin sensitizers, they could be on insulin secretagogues, they could be on insulin. But they were all allowed to be involved. And we put them on a continuous glucose monitor for 5 days. So this checked their glucose around the clock for 5 days continuously, but the patients were blinded to the results. So they actually didn't know what their glucose was at the time. We downloaded it at the end of 5 days and then went back and showed the patients. And we were really startled by the results. Almost half the patients had a hypoglycemic episode within those 5 days, with a mean episodes of 1.74 episodes in that 5-day period, much higher than we had anticipated. And 75% of those patients experienced a nocturnal or asymptomatic hypoglycemic episode. These would be times when they may not feel them, and if they don't feel them, that might mean they're having too many. We also found, as no surprise, that insulin or insulin secretagogues that are glucose independent had a much higher risk of hypoglycemia, statistically significant. And those people that had hypoglycemia actually had higher glucose variability. And so patients didn't notice the lows, they were noticing the highs, but those highs were a response to the lows. So as a response to this real-world study, we found that actually 2/3 of our patients ended up having changes in their medication algorithms as a result of this study. So again, this should really highlight that hypoglycemia is very common in type 2 diabetes. And if you don't ask about it, your patients might not talk to you about it. So in summary, we know that people with type 1 personally will have more individual episodes of hypoglycemia than type 2 because of the impairment of the first and second phase of defenses. But there are so many more people with type 2 diabetes that the absolute number of hypoglycemic episodes occur more often in type 2 diabetes. And many of you will be seeing many patients with type 2 diabetes, and we need to know that you're asking your patients, assessing them for hypoglycemia, their symptoms, and how they treat it. So now we'll talk about the morbidity and mortality and why it's important to identify it and treat it. So these are 3 large studies looking at type 2 diabetes and intensive control versus standard control. And you can see that in all 3 of the studies, there was a substantial increase in the number of patients who had at least one severe hypoglycemic episode during the trial with intensive control. We know that our medications for diabetes are not so refined for most patients. We can push them all the way to the normal level without some risk. And the risk is really exemplified by an increase in severe hypoglycemia. So in those same 3 trials, that severe hypoglycemia actually predicted mortality in these patients. So you can see that in the VA diabetes trial, a history of severe hypoglycemia was the strongest independent predictor of mortality at 90 days. Severe hypoglycemia was increased with increased mortality in both groups, and that in the advanced study, severe hypoglycemia also increased mortality. So not only do these severe hypoglycemic episodes feel bad at the time, but they increase mortality. So how do they increase mortality? We actually do not know for sure, but we believe that this has largely to do to cardiac dysrhythmias. We think that when you become hypoglycemic, you actually get an increase in your QT interval, you get an increase in inflammatory mechanisms, you actually get an increase in platelet activations, and all of which should put you at risk for acute coronary problems. But from the best of our knowledge, we think that this is really related to triggering of cardiac dysrhythmias, which lead to sudden death. And this is the primary cause of mortality related to hypoglycemia. So with this in mind, I want to go back to hypoglycemic unawareness, because many of the people who die with having pre-existing hypoglycemic unawareness. And I'm going to give you a little taste here that in this slide here, I'm showing you a person who's got a continuous glucose sensor. So they actually are able to see their glucose on a monitor continuously. And one of the newer pumps actually has the ability, insulin pumps, has the ability to shut itself off when your glucose goes too low. So this is, for example, a threshold suspend. When it gets to a certain level, the pump turns off. So back to hypoglycemic unawareness. I told you that the epinephrine system is a bluntable system. And because of that, people who experience hypoglycemia are actually more likely to have more hypoglycemia. So if someone drops low and they drop low at 50, they're going to then typically have a problem where their sugar is going to go up. They're going to continue to treat that, but they might not feel the next hypoglycemic episode till they're 45. And so this blunting of the epinephrine response actually increases the risk of future hypoglycemic episodes by 25-fold. Now, the good news about this is that this blunted response can be restored back to normal, even with long-standing diabetes and even with long-standing hypoglycemia. So if you have a patient who comes in, particularly with type 1 or who's on insulin, and they have hypoglycemic unawareness, the first thing you want to do is really urge them to be very vigorous about checking their glucose and documenting when they drop low, because maybe they're able to do some things behavioral-wise to prevent that. But number two, we actually need to reboot the system so that the body will respond to epinephrine. And so the way that we do that is we actually back off treatment to allow permissive hyperglycemia for somewhere between 2 and 3 weeks, so that there's an absolute cessation of hypoglycemia during that time. And if you do that, the body will reboot and then have a normal response to the epinephrine, a normal epinephrine response to hypoglycemia. So it resets the glucostat. So let patients know that hypoglycemic unawareness is serious, it is dangerous, but it can be prevented by rebooting the system. And the reason why you want to prevent it is you want to prevent sudden death. This is actually a case report that was published by one of our colleagues at the East Carolina University Diabetes Fellowship Program. And they actually had a patient who died while they were on a continuous glucose sensor. And you can see that this person had hyperglycemia. They were continuing to treat. And when the glucose dropped quite low, the body was trying to respond, but was unable to respond, and it actually was at a very low threshold before it started to respond. And because of this, this person continued to become more hypoglycemic and died. The dead in bed syndrome is been something that's been defined in type 1 diabetes, where people who appear to be healthy other than type 1 diabetes are found dead, and the current theory is that they're found dead because of hypoglycemia and cardiac dysrhythmias. And so it's, again, very important to identify hypoglycemic unawareness and treat it. So now I want to move briefly to why hypoglycemia is so important in the elderly. We know that we have an aging population and that your risk of diabetes goes up as you age. More than half of people who are above the age of 65 have diabetes or prediabetes. Most of them have diabetes. And many of them are in fixed incomes. And so they're much more likely to be using older medications like sulfonylureas. Sometimes they'll need insulin because of the long duration of diabetes. And we know that those are independent risk factors for hypoglycemia. We also learned that previous hypoglycemia puts you at risk for future hypoglycemia, and that many people who are older no longer eat regular meals because they're not as hungry, or they might not eat as much. And if their medications are not adjusted, they're at higher risk. They're also at higher risk for having abnormalities within their kidney or renal system. So if they're renally impaired, their medications stay around longer. And they're much more likely to have multiple medications on board that might interact with each other and cause hypoglycemia. And so we know that we need to pay special attention to the elderly for the identification and prevention of hypoglycemia. So above and beyond that, the physiology changes as we age. So if you look to the graph on the left, a young man, and you look at the glucose, again, these are people without diabetes, so the numbers are a little bit different. But if you take a look at where they start to experience hypoglycemia and where they start to have cognitive defects, you can see that in the person on the left who's young, they start to be aware of hypoglycemia in the 60s, and it's not till they're in the 40s that they start to have cognitive dysfunction. So that window is an opportunity for you to feel something and then act upon it. Unfortunately, that window of opportunity is much smaller in an older adult. So they might not feel hypoglycemia until their glucose is much lower, and they're going to still experience cognitive effects, but they might experience it a little bit higher. And so this risk of hypoglycemia is so much greater in the elderly, not only because of all the factors mentioned before, but a changing in physiology in response to hypoglycemia. So I hope that I've impressed upon you the seriousness of hypoglycemia as it relates to diabetes treatments and how it relates to morbidity and mortality. But I also want to highlight what it does for patients. Patients do not like to drop low. They don't feel good when they drop low, and they don't like the repercussions when they drop low. Just like someone who has a seizure disorder is always fearful of having a seizure in public, people with diabetes do not want to drop low in public or when they're doing something where they're responsible for themselves or other people. We know that people will have accidents at work. They'll have accidents behind the wheel. They have public episodes of severe hypoglycemia with seizure or coma. And this identifies them as different, and they don't want to be identified as different. We know that this creates great fear, and in response to that great fear, people might do things to prevent it. They might reduce their medication. They might do defensive eating. And this reduces their quality of life. And so people will do great things to prevent hypoglycemia, even at the expense of worsening their diabetes. And we've already told you that there's an increase in cardiovascular risk. And so it's worthwhile to talk to your patients about their experience of hypoglycemia. How does it bother them or their family members? Because sometimes the fear is their family member. We've had many patients who say that they don't know they drop low at night, but their family members actually stay up at night. We had one patient where her husband said that he gets up 2 to 3 times a night to check on his wife. And sometimes he checks her sugar, sometimes he just feels to see if she's sweating. And so this disease now is affecting the entire family. And so it is a significant burden. And often people will change their treatment to prevent those consequences. So this study is really intended to, or this slide is really intended to highlight those factors. So the fear of hypoglycemia at a patient level is a significant psychological burden. They may limit the aggressiveness of their therapy. They may skip doses, take less than they tell you they're taking. They may have decreased adherence to their diet. We call that defensive eating. Sometimes people are eating not for nutrition, but they're eating to prevent hypoglycemia. It also affects health outcomes. One drop of hypoglycemia can impair your function cognitively for up to 12 hours. So hypoglycemic episodes might change your ability to work functionally at your job. It certainly disrupts other family members. It can disrupt life within the family. And patients will often complain about the diabetes police in their family who don't want them to be high, but they also don't want them to be low. And sometimes these are caused, the hypoglycemic episodes are caused by factors that the patient's unaware of, and they feel attacked. And then sometimes people will have a severe hypoglycemic episode, and they'll do anything necessary to prevent that from ever happening again, which means that sometimes they'll have subtherapeutic treatment of their diabetes. Just an interesting note, one of the future studies we'd like to look at is the use of osteopathic manipulation to see if we can raise glycemic awareness. There has been some evidence that you can actually do body awareness training with the use of manipulation. And could manipulation actually improve someone's awareness of their glucose so that they could be better at identifying and then treating or preventing hypoglycemia? So let's talk about the treatment of hypoglycemia. And this treatment of hypoglycemia is in response to people who have diabetes. And again, this slide is really meant to tell you that the psychological fear that people have of having a hypoglycemic episode is not trivial. So when we look at the treatment of hypoglycemia, it's important to know what environment they are in and how low the glucose is. So if someone has a hypoglycemic episode and they're able to take care for themselves, they're able to check their glucose, they're able to eat something, we use the rule of 15s, which is 15 grams of carbohydrates and recheck in 15 minutes, and I'll highlight that in a little bit more. If someone becomes unconscious in the outpatient setting, or let's say in an extended care setting, we would typically use glucagon. Glucagon is a subcutaneous injection that is a rescue medication to use to treat hypoglycemia and diabetes. And then typically in the inpatient setting, many patients have IVs, and we might use IV dextrose, like an ampidextrose, to treat hypoglycemia. So we need to know all of these treatments, and we also want to know when and where we would use them. So the rule of 15s, again, documented glucose less than 70, the person is responsive, they're able to take care of themselves. We want them to take 15 grams of a fast-acting glucose, something like glucose tablets, glucose gel, a small box of raisins, a small juice box, but it should be something that is a pure glucose. Often you'll see people want to take peanut butter crackers or a peanut butter and jelly sandwich, and while these have substantial carb amounts, the protein and the fat will actually make it longer before the glucose can respond. So the first treatment should be pure glucose. Once they've taken that pure glucose, they should wait 15 minutes and recheck. And this is very hard for people to do because when they feel like they're dropping low, they're anxious and they feel like they're going to die. And many people will eat many, many calories in that 15-minute time and will have rebound hyperglycemia. And so it's really important for people to be kind of diligent about, one, using a fast-acting glucose, and two, being patient enough to let the body respond to it. Now, if someone has dropped low, let's say from a basal insulin, and they're at risk for dropping low again before their next meal, their second response could be a mixed nutrient snack. But you really want them to use the rapid-acting glucose as the first response to hypoglycemia. And then you would repeat this rule of 15s until the glucose normalized. We have a protocol within our office that all patients with diabetes get their glucose checked when they're presented. If their glucose is below 70, they're supposed to get 15 grams of glucose. Someone should stay with them personally while they ingest these and recheck the glucose every 15 minutes until it's above 100. And generally, we will not let someone go home if their glucose is low because we're really concerned about the risk of a recurrent hypoglycemic episode, them getting behind the wheel driving home from their doctor's appointment and putting themselves or someone else at risk. So these protocols are important to prevent the patient and the people around them. Now, if the glucose drops further, glucagon is the EpiPen for hypoglycemia. I believe that all patients who have insulin should also have glucagon. I probably write hundreds of these per year, and maybe only a couple get used. A person would never give themselves glucagon to themselves. Glucagon is always given by someone else to a person who is unconscious or unable to take care of themselves. Glucagon is a very effective way to treat hypoglycemia. It typically will raise the glucose by at least 25, often quite a bit more. It does have a fair amount of side effects though, so many people feel nauseousness or vomiting afterwards, so be prepared for that kind of response. And it's my opinion that anyone who's been treated with glucagon probably still has to go to the emergency room so we can determine the cause of hypoglycemia and prevent recurrent hypoglycemia. These kits are good for 1 year, and so I have to renew them annually. The good news is that there's ongoing studies, and it's very likely in the next couple of years, then rather than this complicated kit that has to be made into suspension, that we will have a glucagon nasal spray available to use for people with hypoglycemia. This is not yet available on the market. And then finally, you want to be able to talk with your patients about hypoglycemic prevention. So at each visit, you should be asking your patients, do they experience hypoglycemia, how often they experience, and what they do about it. And you also want to help them prevent that from happening in the future. So you want to discuss with your patients about their medication and their food plan. If they're doing defensive eating, let them know that one of the options you have is you could reduce their medications. That's another way to prevent hypoglycemia. I think it's also important to talk with them about what their triggers are or what situations put them at risk for hypoglycemia. So if there's a change in physical activity, or if they're going to drink alcohol, or if there's something else that, let's say that they have abnormal renal function and they're going to have some CT scan done. It's important to let them know what their plan should be with the medications to prevent hypoglycemia. We also want them to be checking their glucose regularly. This is so important in the prevention of hypoglycemia and allows patients to be able to see what their risks are. I encourage my patients who are anything that can drop them low to carry a glucose source with them regularly. And it usually should be something that's available, that is effective to treat hypoglycemia, but they're not going to want to eat it when they're not hypoglycemic. So I find that glucose tablets or glucose gels work very well. I find that they taste terrible, and I would not normally want to eat them unless I was low. If I had something like Lifesavers, I probably would be eating them when I was not low, and then I may or may not have them when I actually dropped low. And then people who are on insulin or at high risk for hypoglycemia, they should have glucagon strategically placed around their life. So that might be at their workplace, that might be at home, and you need to teach the people around them how to use it. And then we strongly recommend people who have diabetes have some medical identification. We have found that many people who have medical IDs, this can save their life. So if they're found unconscious, immediately knowing that someone has a hypoglycemia, it can help get effective and timely treatment. Further, the highway patrol will tell you that sometimes people present with hypoglycemia and they're irritable and they're agitated and they think that they're on some illicit drug. But if they see a medical alert, they'll know to think about hypoglycemia as a cause and can get them timely and effective treatment. What I've seen from any of my patients, my younger patients now, they've actually gone on to develop or gone on to get tattoos that are their medical alert. So again, it doesn't matter to me whether it's a bracelet, an anklet, or a tattoo, but they should have, or a card, they should have something that alerts people around them that they have diabetes. So our last topic is when hypoglycemia occurs in the absence of diabetes and typically in the absence of the medications for diabetes. As I told you, this is not common. So if I have a patient who has no known diabetes and no known diabetes treatments but experiences hypoglycemia, there's a couple things that I want to assess. First of all, I need to know when they drop low. Is this after meals? Is this in response to meals? Does the components of the meal matter? Or does it occur completely separate and unrelated to meals? Does it occur in the middle of the night? Does it occur first thing in the morning? Does it only occur after they drink alcohol? What's their past medical history? Do they have things like hepatic or renal failure? Do they have any endocrinopathies? All of these things are very important when we're trying to sort out hypoglycemia in the absence of diabetes. And we're going to talk a little bit about reactive hypoglycemia, alimentary hypoglycemia, And then we'll separate post-absorptive hypoglycemia is really a completely separate cause that has a different workup. So let's talk about postprandial syndrome or reactive hypoglycemia. This is not very common, but it does occur, particularly in people who are at risk for type 2 diabetes, maybe when they have prediabetes. So they typically experience hypoglycemia usually after meals, and it's usually within a couple hours after meals. And it might be worse when they have a pure carbohydrate or less of a mixed nutrient meal. And people will typically feel low after they eat, and they'll want to eat again. And sometimes this can be a recurrent cyclical problem. One way to identify this as a problem is to do a glucose tolerance test. And so if someone takes a glucose tolerance test and they get a drop in their glucose from the peak value to the nadir of 75 points, that's really a rapid drop, and that can cause symptoms in hypoglycemic symptoms. And those values still could be normal. They could be in the prediabetes range, let's say from 160 after taking glucose tolerance all the way down to, say, 75. And they could cause symptoms from that. Most people who have reactive hypoglycemia actually are hyperinsulinemic. And so this occurs in the period of time, as we talked about in the type 2 diabetes lecture, early in prediabetes and early in type 2 diabetes. And if the person makes dietary changes, they can usually prevent that. So the way that we prevent that is to eliminate refined carbohydrates, to really minimize the intake of carbohydrates by themselves, and maximize mixed nutrient foods. So things that have protein and fat will slow down the absorption of the glucose, which then in turn will delay or blunt the increase in insulin in response. So we tell them to avoid juices, avoid sodas, make sure they have protein or fats at the beginning of their meals so that they can actually have a coordinated response to limit the insulin response to their meal. Most people with reactive hypoglycemia see this as problematic, but it's not a serious condition. It's really just more of a problematic condition, but it does give us a chance to highlight ways that they can prevent type 2 diabetes. Next, we'll talk about alimentary hypoglycemia. Alimentary hypoglycemia is an interesting phenomenon. So this is closely tied to irritable bowel syndrome. Tends to be most common in young, thin women, but this can also occur after Roux-en-Y surgery for people who have had bariatric surgery. So what happens? When we eat food as early as our mouth, we start to stimulate amylase and can stimulate insulin secretion. But as food gets to our stomach, we're expecting to have a mixed nutrient meal and that our GI absorption will take time. If we have a condition where our GI transit is too rapid, like diarrhea predominant irritable bowel, or Roux-en-Y where you don't have the same absorptive capacity, you'll get the insulin secretion, but you won't get the proper nutrients absorbed, and this can result in post-meal hypoglycemia. This can sometimes be serious. It's almost always tied to the meal, and there's currently no FDA-approved treatment for this. We do use sometimes antispasmodics to allow the slowing of the GI tract, but we also have used off-label DPP-4 inhibitors, which seem to allow a glucose-dependent insulin response to this condition, and it really has been very effective in reducing alimentary hypoglycemic episodes. Albeit that's off-label. So finally, we'll talk about post-absorptive hypoglycemia. And in the absence of diabetes, this is the most severe form of hypoglycemia. This typically will occur at a time that is completely unrelated to meals. It may occur in the middle of the night. It may occur first thing in the morning, or more than 4 hours after meals. It doesn't seem to have any pattern, and it doesn't seem, and the symptom and the hypoglycemic episodes for most people with post-absorptive are quite severe. So in our kind of evaluation of this, we want to be able to, one, first catch hypoglycemia. So we give these patients glucose meters. If we can indeed document hypoglycemic events that are post-absorptive, then we're going to want to assess what was their insulin measurement at the time, because we know from the normal physiology at the beginning of this lecture that when our glucose gets low and you're normal, you should be suppressing insulin secretion and enhancing glucagon secretion. So we want to actually see a suppressed insulin production at that time. And then we also have to be very astute for looking for iatrogenic or spirulous causes of post-absorptive hypoglycemia, including exogenously dosed insulin and sulfonylureas. Haven't had any cases since we've joined Toro, but I used to get about one case per year where someone would come in with severe hypoglycemia, and they were taking insulin in the absence of diabetes, maybe like a case like Munchausen syndrome, or for even more dark reasons where a person would be trying to hurt another person by giving them sulfonylurea medications when they don't have diabetes. So when we do the laboratory evaluation for post-absorptive hypoglycemia, we often do this on the inpatient setting. We don't want to put the person at risk, so we admit them to the hospital, and we actually fast them for up to 72 hours. And the great majority of people who fast for 72 hours who have post-absorptive hypoglycemia will indeed experience a hypoglycemic episode during that time. And so when someone has a spontaneous episode of hypoglycemia, particularly with a glucose below 55, we're going to want to measure the plasma insulin level. We're going to measure plasma C-peptide, which is a precursor to insulin, and it separates exogenous from endogenous insulin. You can measure the proinsulin, the beta-hydroxybutyrate, which is a measure of ketones. And then we also measure a panel for oral hypoglycemic agents, typically sulfonylureas and glinides. And then, once we've drawn that lab, then we will give a plasma, and then we'll give glucagon. And when we give glucagon, we expect a response of at least an increase of 25 milligrams per deciliter of glucose. But this is actually something that's quite complicated and has to be timed quite well. So if I'm evaluating someone for post-absorptive hypoglycemia, I'll actually have a whole protocol written and glucagon at the bedside, because we don't want to treat till we've documented these other lab abnormalities. So this graph is really meant to kind of compare the causes of post-absorptive hypoglycemia. So again, I have someone who I suspect has post-absorptive hypoglycemia. I've already documented a low reading. And if you look at someone who's been given a sulfonylurea, we know their glucose is low. Their C-peptide is high because the sulfonylurea is stimulating endogenous insulin production, and their insulin level is high. If you draw a lab and you get a sulfonylurea level, it's going to be positive. So this is the way that you're able to diagnose that. If someone's getting iatrogenic exogenous insulin, they experience hypoglycemia, their C-peptide will actually be low because their body is actually trying to suppress their own insulin production, but their insulin level will be high, and if they're not getting sulfonylureas, that will be negative. And then if we look at an insulinoma is a tumor, a pancreatic tumor, that secretes insulin independent of its relationship to glucose. And so these people develop post-absorptive hypoglycemia. They have a low blood glucose, but because they're secreting endogenous insulin, they'll have a high C-peptide and a high insulin level, but they're not taking sulfonylureas, so they'll have a negative sulfonylurea level. So just in summary, when you have post-absorptive hypoglycemia, we really talked about the more common causes, which include medications, such as sulfonylureas, glinides, and insulin. We also talked about tumors like insulinomas, but there are other less common causes, such as some other medications like high-dose aspirin, rarely from sulfonylureas or quinine. Again, alcohol is a cause of hypoglycemia, so that should be included in the history. And then certainly liver failure from its inability to produce fasting hepatic glucose production. As you also have probably learned in your endocrine block, there are other endocrinopathies that can sometimes result in more mild forms of hypoglycemia, including deficiencies in growth hormone, cortisol, or glucagon. So let's move to a summative case. So you have a 20-year-old college student who's brought to the doctor from her family members because she's had recurrent symptoms of hypoglycemia, and it's finding it hard to keep awake and function. In fact, one of these episodes, she was taken to the emergency room, and she was found to be agitated, confused, and diaphoretic, and someone astutely checked their glucose, and her glucose was 35 milligrams per deciliter. Certainly abnormal by all intents. What was unique about this case is they all happened to have ordered a C-peptide level at the time of her glucose, and it was increased. And going back to history, and this is something that's actually very tied nicely to insulinomas, is that she had unintentional weight gain. Remember that insulin is a growth factor, and so not only can it cause hypoglycemia, but it can also cause weight gain. And so hypoglycemia and unintentional weight gain goes very nicely for insulinomas. Now, the history is further complicated that her mother has hyperparathyroidism. She has an aunt that has a pituitary tumor. So now she's got an endocrinopathy history, including multiple different organs involved. So as you start to think about this, first of all, what's the cause of her hypoglycemia? And then two, what's the most likely mode of inheritance? So this person very likely has an insulinoma. Again, she's got post-absorptive hypoglycemia. It is severe. It's been documented. We would actually put her through the entire testing in this scenario. But based on that family history, we also should be cognizant of multiple endocrine neoplasia, which is a polyendocrine neoplastic condition that is past autosomally dominant and typically involves the pituitary, parathyroid, and pancreatic cells. And so that's very likely to be the cause of this person's hypoglycemia. But first, let's make our diagnosis of an insulinoma. So for her, insulinomas, again, insulin release is endogenous. It's not related to intake and certainly not related to food taken. It's a rare condition. It is a component of multiple endocrine neoplasia 1, and we've kind of talked about the lab values. In this scenario, you would probably end up doing imaging to see if there's a tumor. Unfortunately, only some of these tumors are visible. So sometimes they're not visible, and then it's harder to assess. If you have a visible tumor, you can surgically resect it. If it's a microadenoma, you may be stuck with using medicines to treat. But it is a rare condition, and it's good to know that it is a form of post-absorptive hypoglycemia. So how can technology help us with hypoglycemia? And there's really a lot to be offered now. You'll get more of this, or you have gotten more of this as part of the type 1 diabetes lecture, but we now have the ability to do continuous glucose sensing, and this is really going to help us raise awareness about hypoglycemia. So you can see here on the top right, this person is wearing a continuous glucose sensor that is Bluetooth communication to a monitor here that actually will show your glucose at that given time. If we go down to the bottom left-hand corner, this device actually has the ability to Bluetooth to another device within someone's home or to someone else's phone. So we have kids that have type 1 diabetes. They can be wearing their glucose sensor, but then also family members in another room can see what the glucose level is at any given time. We also have insulin pumps, both here and this is the sensor attached to another pump that actually can not only communicate with the monitor, but it can also communicate with your iPhone. And so you can actually get alerts via your iPhone or your smartphone, rather, to identify your glucose. And this also can be shared with other members. And so we have sometimes a spouse that will be at work, but be able to receive notifications when their loved one's glucose is high or low. This is a mixed bag because sometimes people want to share that and sometimes they don't. Next, there are pumps that insulin pumps that will shut off when your glucose goes too low. This, to me, will be a major advance, or is a major advance in the management of type 1 diabetes. And those outpatients, there has now just been recently approved the Freestyle Libre, which is a patch sensor. So that you put this on your skin, and for 2 weeks, you can get a continuous glucose reading. And this may actually replace fingerstick glucose readings in the future. So all of this, I hope, will decrease the burden of hypoglycemia in the presence of diabetes. But these sensors can also be used diagnostically for both diabetes and for those people without diabetes. So in summary, we talked about hypoglycemia and that it's very common, absolutely more common in type 2 than type 1 when you look at the summative events. We have redundant physiologic mechanisms to prevent hypoglycemia in those without diabetes. We need to know that hypoglycemic unawareness is a serious condition and can be prevented. We know that hypoglycemia can increase morbidity and mortality. And we want you to know the treatment for hypoglycemia based upon the severity of the hypoglycemia and the setting. And that as providers, you really should be assessing your patients at each and every visit who have diabetes for hypoglycemia, educating them about the prevention, the timely identification, and the treatment of hypoglycemia. For those that want more information about hypoglycemia, I have Philip Cryer is really the father of hypoglycemia in the United States currently. I've included the Endocrine Society evaluation of hypoglycemia in and outside of diabetes, and we had written a review article on hypoglycemia both in and outside of diabetes. I hope you found this to be useful, and we look forward to seeing you in the review sessions and the summative cases.